Welcome friends, welcome viewers, welcome on MuniMeterHealth, your source of learning about human heart and cardiology. I'm Dr. Jaitly, your cardiologist. Welcome again on MuniMeterHealth. Just like I always do, housekeeping rules first. This is purely an education channel, so just be mindful that this is only for patient education and medical education. We are not giving you any medical advice, and we know that patient education, medical education, when combined together, results into a profound enhancement of clinical outcomes. Okay, so if you're having or experiencing any emergency, please dial 911 if you're in America, and get to the nearest hospital, to the doctor, or call for an ambulance, please. Okay, now what is pulmonary heart disease? And that is being discussed in this short video. Pulmonary heart disease is also called cor pulmonale, or heart affection secondary to the lung condition. So remember that. So what is primary? The primary is the pulmonary problem, and that is normally a pulmonary hypertension problem, and a primary pulmonary hypertension problem results into essentially the right-sided heart disease. Now, you must be wondering, why am I showing the ventricles on the top? Well, this is your 2D echo, okay? A 2D echo always conventionally shows the ventricles on the top and the atria at the bottom, just so that you know, although the heart is inversely positioned in your chest, and my chest. This is for the sake of the medical students and general people. But of course, the cardiologists and the fellows, they already know, the residents should know. But the whole idea is wanting to see that if this is a 2D echo image, the ventricles are depicted on the top, and the right atrium, left atrium conventionally are shown at the bottom when you're taking the image. Now, very essentially, just so that you know, coming back to the definition, so pulmonary heart disease results from a primary pulmonary condition affecting the right heart disease, right heart chambers. So the right heart chambers, which are right ventricle and right atrium, they will be affected by the pulmonary condition. Now, if it is, there are only two things that can really affect predominantly the pulmonary conditions, and they are either lung conditions, they are like COPD or chronic asthmas or emphysematous conditions, or chronic bronchitic conditions or asthmatic conditions, or vascular conditions like pulmonary embolisms, as we call it, or PE. So there's chronic venous thromboembolic conditions or acute embolic phenomenon. So they will all result into pulmonary hypertension. Now, we should know what the normal pulmonary arterial pressure is. Normal pulmonary arterial pressure is about 25/10. Anything more than that is considered as pulmonary hypertension, just so that you know. Okay, so it's very important that pulmonary hypertension is defined where the pulmonary arterial pressure. I'll show you briefly how we calculate that in a second. So having understood what pulmonary heart disease is, pulmonary heart disease, therefore, once again we'll define, is affecting the right side of the heart because of a primary pulmonary condition. Remember. Now, what is pulmonary hypertension? Secondary pulmonary hypertension? A secondary pulmonary hypertension results from a left ventricular problem or a left atrial problem. If you have left-sided heart disease and that results into pulmonary hypertension, that is called secondary pulmonary hypertension. So remember, primary pulmonary hypertension, I'll write it down here for you guys, precedes the cor pulmonale, or precedes the right-sided heart disease, whereas left-sided heart disease precedes the secondary pulmonary hypertension. I made it very simple for the students and for everyone here, so that we just understand that as here we go. Okay, so primary pulmonary hypertension precedes right heart disease. Left heart disease precedes secondary pulmonary hypertension. This will be on the boards, on the questions, directly or indirectly, so certainly will be very helpful for your exams as well. Now, very quickly understand, the left ventricle is normally the bigger brother, so we call it the big brother. So LV size is always bigger than the RV normally. So therefore, I say LV is bigger than the RV in the size if you look at the two-dimensional view. And here I've tried to show the LV size is bigger than these are the valves here, of course, the right tricuspid valve, and this is the mitral valve. So the left ventricle is more than the size of the right ventricle, and that is considered as normal. You cannot really tell based on a 2D image if there is a mild pulmonary hypertension just by looking at the size. You have to measure the pulmonary arterial pressure. So this is just a gross way of knowing it. But if the LV size is equal to the RV, or the RV is now starting to enlarge, and now the big brother and the small brother, you can't tell by the size, the two sizes are the same. That means the RV has started to enlarge here. I can show it like this. And this surface area, or the volume area, we calculated based on the 2D images here. Then we know it is moderately enlarged right ventricle. And obviously, if the RV becomes the bigger brother, the quote-unquote the bigger brother, then the left ventricle, and it's now even bigger than that. And sometimes you can see a hypertrophy of the free wall. If the hypertrophy is seen, there, or RVH is as well present, we can write it RVH, then we know it is severely, then we are looking at a severe enlargement of right ventricle. So that has to be explained why. Now, sometimes the tricuspid regurgitation is present, which is concordant with the amount of pulmonary hypertension that is present. However, the caveat is you may have severe pulmonary hypertension but may have a mild TR. So TR is not sine qua non of pulmonary hypertension. However, it's a good way to measure the pulmonary arterial pressure. Now here's how. Bernoulli equation is basically telling you that there's a delta or change in pressure between the right ventricle and the right atrium if you were to measure the tricuspid velocity. Now let's look at the tricuspid velocity. We can look it up here, right here. If you were to do a tricuspid velocity based on a color, it should appear something like this. Okay, so this is your systolic jet, which is dipping while you're measuring the pressures here, and the tricuspid regurgitation will appear somewhere like this. Okay, I'm showing it to you in different colors so this way we can understand. Now, depending upon where the vena contracta is, again for the fellows, you can measure the vena contracta right here and then define what the tricuspid regurgitation severity is, or you can measure the dPdt as well, or you can measure the short time it takes to really accelerate to the peak velocity. You can measure that, and then of course try to look at the notch sometimes here, and a notch will define the mid-systolic deceleration. So there are a lot of ways you can measure all this tricuspid regurgitation. But in general, what you do is you take the grayscale and measure exactly the velocity, the peak velocity of the TR. We call it the tricuspid regurgitation. And as soon as you measure that, that's in meters per second. Remember, this scale is in meters per second. So you have 1, 2, 3, and then 4. Say it is 4 meters per second. So like I cited this example, 4 meters per second. So you equate that, and assuming that the right atrial velocity is only 1 meter or less, then by this equation, RV minus RA is equal to 4V square. So the velocity here being 4, you compute that into this equation, the Bernoulli equation, and you come up with numbers called 64 millimeters, which is 4 times 4 times 4. Okay, so 4V square. That gives you the delta P, or the pressure gradient across the valve between the right ventricle and the right atrium. Okay, so this is Bernoulli equation, which is beyond the scope of the current, our video, but just so that you know, we are defining the pressure gradient. Now, pressure gradient plus the right atrial pressure, just add that to the right atrial pressure and you'll get the pulmonary arterial pressure. As simple as that. So in a nutshell, it's very, very important if a patient is presenting with acute chest pain. Now, this is very important. Somebody's presenting with acute chest pain, somebody's presenting with shortness of breath, or somebody's presenting with, say, unexplained tachycardia. Heart rate is more than 100, 120, 130 and presenting in the ER. Or is presenting with syncope and dizziness, etc. Now, these are very, very important symptoms. And if you were to do an echo, and an echo suggests a change in pulmonary arterial pressure, PAP, from the baseline. Say 6 months ago, that same patient had an echo, or a year ago as a regular follow-up had an echo, and the pulmonary arterial pressure was normal. Or the pulmonary arterial pressure is significantly high and you're doing a first-time echo in this individual and you have pulmonary hypertension in the presence of these symptoms, and you have a pulmonary arterial pressure which is extremely high. We call it pulmonary hypertension here on the right side of the screen. That patient, you should rule out pulmonary embolism unless proven otherwise. So PE must be ruled out in those patients unless proven otherwise. And pulmonary embolism is one of very, very, acute illness, and obviously it has severe morbidity and mortality unless treated immediately, so it has to be immediately checked. So acute pulmonary embolism is defined as patients presenting with any of these symptoms and demonstrating a pulmonary hypertension of a very severe variety by a 2D echo. You obviously have to confirm by VQ scans. You have to do the whole D-dimer testings and put this patient on anticoagulation protocol. Call the cardiologist, call the pulmonologist, admit the patient to the ICU, CCU, etc., etc., etc. But that's beyond the scope of the current video. The whole idea is wanting to define what is pulmonary heart disease in this individual, and of course understand what is a distinction between a primary pulmonary hypertension versus a secondary pulmonary hypertension that is present. So primary pulmonary hypertension, which is defined as pulmonary arterial pressure more than 25/10, either resulting from a lung condition or either resulting from a vascular condition, will result into affect the right side of the heart. So remember, so that is the primary pulmonary hypertension. Whereas the left-sided heart disease, that precedes first, whether it's mitral valve disease, whether it is congestive heart failure, whether it is mitral stenosis or mitral regurgitation, or some form of cardiomyopathy, etc., or coronary artery disease. If that proceeds first and then you develop a pulmonary hypertension, that is considered as secondary pulmonary hypertension. So in a nutshell, you have understood what Bernoulli equation is. How do you calculate the pressure gradient? How do you compute the pulmonary arterial pressure? By adding the right atrium to the pressure gradient. And remember, right atrial pressure is measured very simply by noting the size of the IVC about 1 or 2 centimeters. Remember, about 1 to 2 centimeters away from the right atrium in a subcostal view. This is mainly for the cardiology fellows here. Of course, the residents and students may not be interested in knowing that, or may not be aware of it yet. But the fact is that this is for the cardiology fellows to brush up for the exams. 1 to 2 centimeters away from the subcostal view, if you were to do the transducer and a 2D image, one can measure the IVC size. Then also look at the IVC size in terms of what's happening with the respiratory phase. If there is an inspiratory collapse more than 50%, or if it is less than 50%, that will define the amount of right atrium, and there is different criteria for that. If you want, I can quickly define that also. RA is, remember that if it's 0 to 5, and when you have an IVC size less than 1.7, and the IVC collapses more than 50%. Now, if anything beyond IVC, if you have IVC size more than 1.7 and your collapse is less than 50%, then the pressure gradients, the RA pressures could be about 10 to 15. And if there is no change, remember, if there is no change in the collapse and the IVC is still more than 1.7 centimeters, then the pressure gradients are more than 20. So just so that you know. So if there's no change in the respiratory phase, during the respiratory phase of the IVC, in other words, doesn't collapse and doesn't increase, etc., obviously it's not going to increase. But the fact is that there's no change, then you can compute 20 millimeters here for your right atrial pressures, whereas the delta P is, of course, calculated based on the Bernoulli equation. Okay, so having defined all of this, hope you enjoyed this very short session on pulmonary heart disease, which is a very, very important subject, and hopefully it'll help you in your exams when you go for your American Boards of Internal Medicine or Cardiology, or the national boards for the students. And of course, for the USMLE, I think the students will appreciate this input that I have offered to them in this very, very short video. Looking forward to seeing you again, and let's do another teaching round on my next video. Okay, please join us on MuniMeterHealth. Thank you so much for watching.